Good afternoon once again. I realize I always jump on stage and I don't introduce myself properly, so I'm really sorry. My name is Damaris Nyamoya. I'm from Nairobi, Kenya. I'm the president and co-founder of Operation 000. It is an initiative for adolescents and young people living with HIV. We are aiming and we are gearing towards viral suppression. So if you'd like to know more about OTZ, kindly just come to me and I'm sure I'll give you a lot of stories that you will really love. I would also like to introduce my co-chair for this session, who is Alice. Kindly, Alice.
Thank you. All right. Wonderful. So our session today is titled Reaching Adolescents, Those Who Are in Most Need. We are getting out of the box of just the business as usual. The business as usual of reaching those adolescents that are easy to find, who are easy to engage. We are today going to look at how we make our programs, ensure that our programs are designed in a way that considers the diversity of adolescents and their needs, while also having a focus on those who have high needs that often drive poor SRH and HIV outcomes. We recognize that we really need to move beyond what we have been doing. We need to move beyond our usual assumptions, and we need to critically reflect on where, who, and how we implement our programs. In the session today, we are going to understand risk, the associated pathways, the need for us to think differently about how we approach those adolescents who are in most need. So we have a wonderful set of presenters, both abstract and a keynote, as well as panelists from different parts of the globe. So we look forward to sharing with you their study findings and their insights from programs. First up, we have Associate Professor and dear friend, Elona Toska, who works at the University of Cape Town and the University of Oxford. And she today is going to do the keynote presentation, which is Targeting for Triumph, HIV and SRHR Programming for a Multi-Dimensional Adolescent Wellbeing. Thank you, Elona.
Hi, everyone. Hope you can hear me okay? Yes. This is actually my own talk, not anyone else's. So all the errors are totally mine. I have no conflicts of interest, but I have a lot of invested interest in this topic and the work because I'm part of a big team, which Mona mentioned earlier, who are all very passionate in trying to understand and do research that supports adolescent HIV and SRHR well-being broadly. So I'm going to tell you, I have 10 minutes, more than, I thought I had 7 minutes. All right, so I said I would only tell you 6 things in my remaining, and these are the 6 things here. First, why target? Then 4 different approaches to targeting, and then last, some thoughts and unique considerations around targeting for 10 to 19-year-olds. Because I know my slides really well, I will continue with the next. Perfect. Mona mentioned earlier that we have a growing body of evidence on what are the different interventions that we can do when we're thinking about multi-sectoral approaches. We know that when we're providing services to adolescents, we need to think about their unique needs and be adolescent-friendly and responsive. We know that peers have incredible power in reaching adolescents. We know that it's important to address the livelihood, food insecurity, poverty-related issues in the homes that the adolescents and communities where the adolescents and their families live in. We know that it's hard to look after an adolescent, right? All the parents of adolescents yesterday were saying how difficult and important it is. So supporting parents of adolescents is also really important. And we've heard today about the power of thinking about schools as a platform. However, we have limited resources. So one of the questions that we all hear is, how do we find those who need the most? Either all 5 of these programs and components, or any combination of them. And this pyramid isn't meant to give us the answer, but it's meant to give us an idea of why we're thinking about this. There are things that everyone should get. How many people here have heard about universal health care? Yeah? So that would be for everybody. It's in the name, universal. But there are some programs that we can only do for some people, and I'll give you a couple of examples of those. And we think about these as maybe people who are at immediate risk or have something that's happening to them that we must address straight away. And then there's a smaller group of people who may actually be having a harder time, and it's very difficult to think about them getting one intervention that addresses all of these issues. So for them, we want to think about understanding these multiple needs and providing multiple components in the suitcase that Linda Gale has been giving us as the idea. So these are 4 different ways that we do targeting at the moment. And some of these are very HIV specific, and some of these are broader. The first one is geographical targeting. And I'm sorry about the text formatting a little bit for the map of Lesotho over here. In the Kingdom of Lesotho, the HIV incidence amongst 15 to 24-year-old adolescent girls and young women is very high. And it's very high across the board. So if we're thinking about using incidence as a way to target, we actually do not have any regions that we would prioritize. We should be doing HIV prevention everywhere. However, if we go to look at, for example, a map of households facing food insecurity in Lesotho, we see that there are some regions that have much higher rates of household food insecurity than others. And if we look at it across the year, we actually see that some parts of Lesotho are hit by droughts, which actually give us additional thinking around programming. If we're thinking about early motherhood and adolescent pregnancy, there's also differences by region. So when we're thinking about geographic targeting, it isn't only about how many people have an infectious disease, but also about the targets, the drivers, and how do we actually understand the patterns across regions and across time. So if you have a drought that happens every year at the same time, what can you do to address the hunger and potentially transactional sex or other high-risk issues that may emerge during the time for young women? The second area that we've done a lot of thinking on is around individual level risk. How many people here have heard of screening for sexual risk and sexual risk behaviors? Anyone? Okay, great. So I don't have to explain this to you, but it's actually highly contentious. It's not very easy to do. And it doesn't mean that the best way to understand individual level risk is to ask me how many people I had sex with last month and how many of them did I use a condom with, and then immediately there give me the perfect combination of interventions. So in this analysis of the Violence Against Children survey in Lesotho, we see that adolescent girls and young women who are most likely to have told in the survey that they had high-risk sex were actually those who had experienced sexual violence or early sex, who were married before the age of 18, who had a pregnancy before the age of 18, and who were not in school. So rather than ask everyone how much high-risk sex they had and how many sexual partners they had in the last year, we could think about these 4 structural drivers and how do we identify them for targeting. Nonetheless, there's actually a lot of screening tools that are going around and are being used, and I think we should keep trying and learning from all of them. However, I was reminded by colleagues in a workshop that we did with peer supporters on Monday and Tuesday of the 5 W's of disclosure. And I thought, gosh, telling people about sex is like telling them disclosing, right? So I think we should think about screening as a story and be very careful about the 5 W's of screening: the who, the what, the where, the when, and the why. And then the how I added, it's not a W, but what do we do with this score that we give someone, or with the answers that they give us? I want to acknowledge this is a very quick overview of all of these tools, so if you want to tell us more about the 5 W's and the how, please go ahead in the Q&A. But in the how, there's actually a lot of different questions that we can ask. And these are some of the tools that are available. The Your Journey tool in South Africa encourages self-reflection. The Heads and Heads Plus tool of WHO and UNICEF are focused on understanding multidimensional issues around an adolescent living with HIV and adolescents more broadly. One can do screening around mental health and substance use, and there's well-validated tools. We heard of the PHQ-9 earlier today. One can do gender-based violence or violence broad screening integrated in antenatal care or in HIV care. Colleagues here in Zambia have been piloting that with work that Dr. Cristina Laurenzi has been leading. And one can also do work that is usually very common in case management, which is more health vulnerability assessments, like PEPFAR work and OVC programming. But there's also groups that are at risk for whom we can do programs. For example, how are we supporting and designing programs for pregnant and breastfeeding adolescent girls and young women? They are multiple times at greater risk than others in the same age group. And Jenny will tell us a little bit about that in her presentation. And what about adolescents living with HIV? It's not always easy to find them because there's lots of issues around stigma and disclosure, but they experience multiple adversities. And all of the factors that resulted in exposure and acquisition of HIV do not disappear the moment a positive test is received. So Mona shared earlier data on multisectoral packages in South Africa. And it's important to think, how do we reach our HIV goals as well as SRH goals, but also education, jobs, and violence prevention. There's really brilliant examples from Ethiopia, and this is my last approach to targeting, about what existing programs can do. Community healthcare workers, when supported with a structured program, can improve not only delaying pregnancy, postponing child marriage, but also literacy and education enrollment in adolescent girls and young women. And this is happening at scale, and I'll tell you a bit more about this if we have time later. There's a really great example in Tanzania called Ujana Salama, where HIV prevention was layered on a social protection program. And look at all of the different outcomes where we observe change. Finally, some considerations. We really need to think about risk in adolescence changing, but also vulnerabilities. And we really need to think how our screening and targeting is taking that into account. Our work should be age and life stage appropriate. A 17-year-old who is a parent is different from a 17-year-old who is not yet a parent, and not just because of their physical and cognitive development, which is also extremely important. Generation Z and Alpha. How many of you are Generation Z in the room? Do you know what that is? Yeah? Generation Alpha? How many Generation Alpha? Not me. My children are Generation Alpha. But you're very different. We can barely keep up with you. So we really need to think about all of our tools and how we do that. But finally, we also just need to get off this mindset of adolescents and as either older children or little adults, because you have a lot of power in you, don't you? And you keep reminding us that even though I think I'm a 17-year-old with 23 years of experience, I also have 23 years of forgetting. My colleague Puma is laughing there. I forget a lot. So peer supporters from KCIA, are you in the room? Yes, can you help me with a cheer for Nothing for Us Without Us? Go for it.
Wow, what an amazing, amazing, amazing cheer. Kindly turn to your neighbor. Just turn to your neighbor. Not with the whole body, just your head. Just turn to your neighbor and look at them and ask them, neighbor, neighbor, who is in need? Did they give you an answer? Ask them again, neighbor, neighbor, what needs do you think they have? I hope by the end of this session they will have given you an answer. So right about now, I'd like to introduce our first abstract presenter, who is Jenny Chen. She is based in the University of Cape Town and also comes from the United Kingdom. She is going to be presenting to us missed opportunities for PrEP uptake among adolescent girls and young women who are mothers at risk of HIV in South Africa. Kindly, let's give a clap to Jenny.
Can you hear me? Yes? Oh, great. Cool. Hi, everyone. I'm Jenny, and I'm so happy to be with all of you here at this workshop today. So yeah, let me get on with my talk. So just a bit of background. Obviously, AGYW are a key population. They're a key group because they do account for 6 and 7 new HIV infections among adolescents aged 15 to 19 in sub-Saharan Africa. And South Africa is where my study is based. The setting has the largest HIV epidemic in the world, with 7.5 million people living with HIV in 2021. And the reason why we care so much about mothers as well is because pregnancy and breastfeeding more than doubles the HIV acquisition risk. So we've heard a lot about PrEP, and so we know that PrEP is 99% effective at preventing HIV infections in all populations when taken correctly. And South Africa introduced oral PrEP in 2016, and they then updated their guidelines per WHO recommendations to also include pregnant women in 2020. So the aim for this analysis was to understand the PrEP experience of AGYW mothers in South Africa. And so the aims were to map the PrEP cascade for them and look specifically at the PrEP cascade among those exposed to HIV risk, and then also looking at the associations with HIV testing. So our study is called Hey Baby, and if you want to find out more, you can go to our website there. But this data was cross-sectional from our 2020 to 2022 surveys, and we have 646 HIV negative mothers in this sample. And the interviews were done remotely because it was during COVID-19, so we had to adapt our methods, as I'm sure a lot of you guys had to as well. And in our sample, it's maybe 16 to 24 years old with a mean age of 21, and most of the mothers had their babies when they were under 20 years old. So jumping into the analysis. So for the analysis, I first did a descriptive analysis of the cascade, and that's looking at the steps of self-reported PrEP knowledge, ever offered PrEP and taken PrEP, and also the correlates, so self-reported HIV testing and exposure to sexual risk. And then I looked at the multivariable logistic regressions for these outcomes and potential correlates as well. So here is the PrEP cascade for our Hey Baby sample. As you can see here, 88% of them said that they had a recent HIV test, but only 51% said that they knew about PrEP, only 16% said that they had ever been offered PrEP, and only 10% had ever taken PrEP. And just to kind of introduce the correlates that I'll be talking about, so there's participants who self-reported any HIV risk exposure. That makes up 69% of our sample, and there were 443 participants. And it's basically those who self-reported no condom use less sex, ever had an STI, multiple sex partners, sex under the influence of alcohol and or drugs, age-disparate sex, and transactional sex. And with participants who had a recent HIV test, that's 88% of the sample, as we saw in the last graph as well. So now looking specifically at the PrEP cascade among those who self-reported HIV risk, you can see that there is barely any difference between the two groups. And this is also confirmed by multivariable logistic regression, where there's non-significant associations between kind of having HIV, self-reporting HIV risk exposure, and then knowing about PrEP, being offered PrEP, or taken PrEP. But then it's a very different story when we look at the association with HIV testing. The blue are those who did not have a recent HIV test, and the pink are those who did have a recent HIV test, and you can see that there is quite a big difference between the two groups. And this is also confirmed by the multivariable logistic regression, where basically we see that there is more than double the chance of knowing about PrEP if they had a recent HIV test, and almost triple the chance of being offered PrEP, and more than quadruple the chance of ever taking PrEP if they had a recent HIV test. So basically, going to the conclusion and considerations, I will also be kind of, drawing in some thoughts from my poster, which is in the poster hall from a review that I did about delivering PrEP. So very few AGYW, as we can see in the graphs, had ever been offered PrEP, and even fewer had ever taken PrEP. And this is despite the fact that 69% of them had self-reported any HIV risk. And also we can see that there is a big difference, and with HIV testing, there were 88% of them who ever had a recent HIV test, and yet only 51% knew about PrEP. So there's like a huge missed opportunity for basically raising PrEP awareness whilst they're doing the HIV testing, or after they get the results, for example. There's just huge missed opportunity here that really could be taken up. So when we think about targeting these AGYW who are mothers, you know, we really need to think about removing access barriers, right? All of us know that. And so we should target them where they already go. And so, you know, we can reach them through existing channels such as antenatal care, postnatal care, so on and so forth. And just for those who might be interested, I do have upcoming linked analyses as well, so this is just a step one in this analysis, but in the future I will also, well, currently I'm also looking at promoting factors associated with successful progression down the PrEP cascade, and also the preferences for PrEP delivery and modality among adolescent and young mothers at risk of HIV, because obviously choice is extremely important for these AGYW mothers. And also just looking, just to kind of mention as well, we are also following up with these mothers to ask them, like now kind of pretty much 3 years later, again, have you heard of PrEP? Have you been offered PrEP? Have you ever taken PrEP? Just to kind of look at if things have changed, you know, over the past years. And yeah, just wanted to say thank you, obviously, firstly to our Hey Baby participants who, you know, obviously let us collect this data, and then also Hey Baby team, my supervisors, and all the funders. But I just also wanted to say a huge thank you to everyone at this workshop, and especially the youth-led voices, because you guys have really inspired me. And I think for me, my hope is that any research that I hope to do will just become tools to make your voices even louder, and so that they can be heard. Thank you so much. Thank you.
Thank you very much, Jenny, for the wonderful work you're doing. And I know most people will be flooding your poster. So kindly remember poster number 70. That is where you'll find Jenny. Right about now, I'll also like to introduce our second abstract presenter, and then we'll go to the Q&A. Our second abstract presenter met me the first day, finally enough, and asked me, are you going to make us dance again? He just decided to threaten me early in the morning, but it's okay. I know when we were in Cape Town, I gave him a hard time. So our second abstract presenter is Daniel Mwamba from Zambia. He's going to present to us the prevalence and factors associated with risky sexual behaviors among female adolescents in Zambia. Thank you.
Good afternoon. I don't have any conflict of interest, but there is my disclaimer, and bear with me, pardon my French accent, English is not my native language. So one thing we know about adolescents is they are risk takers. They like trying out new things, they want to discover, they want to venture into adventure, and they want to try all the new things that are out there. But sometimes this risk taking doesn't always end well, and put them at risk of various adverse health outcomes, like unwanted pregnancy, HIV, and STI. And data we have from Zambia shows that female adolescents, 15 to 24, are 4 times more likely to get HIV than the male. And for those who get pregnant, globally, 1 in 3 abortions happens in women below the age of 20. And for Zambia, 29% of adolescents have been pregnant. Out of these, 20% have actually given birth before the age of 15. So based on this evidence, we strongly feel that there's need to better understand the factors that are associated with adolescent risky behavior if we want to put in place remedial plan and to inform program and policy. So we use the Zambia Demographic Health Survey, the 2018. This is a cross-sectional survey that happens every 5 years. It's robust in terms of sampling design, and the one we use sampled 13,625 households, and out of these, we had 13,683 women aged 15 to 49. Out of these, 3,000 were aged 15 to 19, female adolescent girls. And 1,490 were sexually active. So our aim was to explore the prevalence and factors associated with risky sexual behavior among this population. And we also looked at another correlate, exposure to mass media like newspaper, TV, and how that influenced the risky behavior. So how did we define the sexual risky behavior? One was engaging in sex with more than one partner. Secondly, transactional sex. And third, alcohol consumption during the last sexual intercourse. Fourth, having had sex before the age of 16. Then the last one of non-use of condoms at the last sex. So what was the characteristic of our respondents? Majority were age 17 to 19, representing about 60%. They barely more than half had reached secondary and tertiary education level. 85 were not married, and 82% were not working. When we look at distribution across different provinces in Zambia, it was fairly distributed, but of course, Lusaka and Copperbelt leading with more than 30%. Exposure to mass media, we noted internet use was the lowest, with 89% not having access to internet. So what did we find? Among sexually active respondents, 71% actually reported one or more risky sexual behavior. And engaging into sex before the age of 16 was the most commonly reported risky behavior. Then it was followed by non-use of condoms. Then we have a smaller number reporting transactional sex, alcohol consumption, and having multiple sexual partners. So what we concluded, or what we found, is that young adolescents, meaning 15 to 16 years, with less than secondary education and not married, with no access to mass media, and residing in western province of Zambia, were more likely to engage in risky sexual behaviors. We compared these findings with other countries in the region and beyond the region. Engaging in sex before the age of 16 is similar to what we found in Europe, but when compared with African countries, the rate in Zambia was slightly high. We believe this is because of early marriage. But when you take aside early sexual debut, other risk sexual behavior in Zambia were falling into 42%, which became lower than other countries. Low education attainment is associated with more risky sexual behavior, this across the board and across all the literature that we went through. Access to mass media also was associated with less odds of engaging into sexual behavior. We believe that adolescents who are able to access internet, TV, newspaper, and magazines have an opportunity to get the first-hand information, to be educated, and therefore to take informed decisions when it comes to their sexual engagement. We suspect, or we hypothesize, that Western province stand out as having a great risk of engaging to risky sexual behavior because of less economic potential, difficult climate, and geographic region. So in conclusion, what do we say? We strongly feel that to address this issue, we need to approach it in a multi-pronged strategy. And we need to improve economic situation for the adolescent girls, increase health education, very important, but also to facilitate access and utilization of these health services. But also, most importantly, this has to be family-centered, where we need to discuss issues to do with early marriage among adolescent girls. Thank you so much.
Thank you very much, Daniel Mwamba, and I know this also takes us back to our first presentation where Job took us through the triple threat that is currently happening in Kenya: early pregnancies, SGBV, and increase in HIV. So right about now, I'd like us to go into a short Q&A, and I hope you'll address your questions to Elona and the two abstract presenters. So kindly, if there are questions in the crowd, and also from the online team, online participants, you're welcome to ask your questions. Yes, I can see number one at the end. Okay, and then any other question? Yes, we have one up front and another one at the back. So I'll only take the three, kindly. So we can start with number two.
Ms. Mani Moyo, working with Adolescent Treatment Africa. Comment goes to Jenny. She highlighted the missed opportunities when it comes to PrEPUptake. One thing that we have to realize is that pill burden, it's a real thing. It's not something that is just outside of, or something that is not happening. For someone who has been taking ARVs, I understand better when it comes to pill burden. Now we are talking about someone who is not HIV positive, but having to take PrEP each and every day. And that is something that some of our young people are failing to commit to. So the other missed opportunity, we need injectable PrEP because we are tired of tablets, because it's painful drinking tablets each and every day. So to donors, to each and every institutions that are here, that can make it possible for us to have injectable PrEP, make it possible for us young people. Thank you so much.
Thank you for that. Thank you very much. Thank you. Number one, make it short. Kindly make your questions very short.
Okay, so my question goes to Mr. Daniel. So basically, looking at the high rates of HIV among young women and girls. So basically, what laws or what existing laws do you have in order for you to make sure that the strategies that you've put in place are able to yield the desired results, which are basically to lower the number of young people and women that are acquiring HIV? Thank you.
Thank you. We'll have the gentleman at the back in a suit. He was the last person to ask a question.
Thank you so much. I'm Mayama Ramayama from the Kingdom of Lesotho. My question is a sort of comment to the last presentation. It seems education kind of coexists with a lot of the poor, or lack of education seems to coincide with a lot of poor health outcomes, or at least the general economic situation. So I was just thinking, and as far as the conclusions, I saw that there a sort of recommendation for what could be done and areas that we need to focus on. But it doesn't really focus on education, it focuses on sexual education. So my question was, did you make a consideration for maybe also supportive to overall education and supporting people and young people to stay in school, and any other support that could be provided for them to stay in school such that they attain their education? Because clearly, even though we cannot talk about direct causal relationship, but the pre-existence of what we don't want to be dealing with, and lack of education seems to be a pertinent issue. Thank you.
Thank you. Jenny, would you like to go first?
Sure. Thank you so much for that question, because it really is highlighting a very, very important point that is actually, again, I'm not trying to plug my poster here, but I do also say on my poster, basically, you know, a big reason for PrEP discontinuation amongst AGYW is because of the daily pill burden. Obviously, it's hard, isn't it? It's not easy to take a pill every day. And like you mentioned there, like ARVs are a daily pill, and so we don't want to repeat the same stories. And so, yeah, that's why it's extremely important that we push the fact that adolescent girls and young women, and all adolescents obviously need choice. You know, it's not just here, have a pill that works, you must take it. You know, they need to choose what works for them, and which is also like, you know, kind of highlighting kind of my next upcoming analysis as well, is looking at the preferences of AGYW, right? To give them a voice and saying, okay, what do they want? What do AGYW want in the form of either injectable, long-acting injectable, the vaginal ring, you know, or, you know, other upcoming kind of longer-acting pills maybe, for example. But it's important to, again, listen to AGYW, listen to adolescent voices, and let them tell the government, the clinics, what they actually need and how they can continue taking PrEP if they need to take it. Thank you so much for that question.
Thank you, Jenny. Daniel?
Thank you for the question. So some of the strategies that we should put in place to lower HIV among the young, we need first to look at what are the causes. And from presentation that I've just made, you can see that education and poverty really stand out to be the key drivers of high HIV in this population. So we cannot emphasize more on the need to educate the young women and making sure that they remain in school. It's through education that when we provide them with the knowledge and the skills to decide on how they want to live their sexual life. Poverty, it's quite a difficult issue to address because this involves multiple stakeholders at different levels. But at local levels, at community levels, we have programs like DREAMS, like social cash transfers, and most of women that attend these programs, they go through capacity building. They are taught how to be independent economically. They learn few skills that they can utilize and to survive in life. So basically, those are the few things that I would put out there, to empower the women and to educate them. But we also have cultural norms that probably need to change. We believe in our society, particularly in Zambia, that a woman is not supposed to say no to sex when the man wants it. Even in marriage, and when a man wants it, a woman, a wife cannot say no. Even if she knows or she doesn't know the HIV status for the partner, she just has to accept. So those are cultural norms that we may need to discuss at community level and engage community leaders and change those perceptions. But there is more to it. Then the other question on education versus sexual education. I think we cannot separate the two, education or school and sexual education. But what is very important to know is that HIV literacy does not always correlate with the level of education that we have. We've seen people who are highly educated, but with very low HIV literacy. So the best approach maybe would be to look at our school curriculum and make sure that it's really comprehensive, and sexual education is part of the school curriculum. But of course, it has to be tailored to the population and to the age of the student that we are dealing with. I think that's what I can say. Thank you.
Thank you, Daniel, for that. And before I pass the mic to my co-chair, I'd like to ask Elona if she has anything to add on to that, the conversation.
Sorry, there's a lot that we can say, but I think it's quite important to think about biomedical products and solutions as very empowering, but it's not the first time something has come through. The contraception mix is now in all of our policies. Now we have it in antiretrovirals. Now we want it in PrEP. It's not the first time these ideas are coming up. And the fact that to get to the effective use of all of these, we need psychosocial support. We need to not be hungry. We need to be able to go to school. We need parental support. None of these are new. So how we get this learning across and think about the effective use of these beautiful tools that our scientists are developing is quite important, but we shouldn't start from scratch every time. Over.
Awesome. Thanks to all our presenters, and we're actually going to have a little bit more time now and a little bit of a panel discussion. We have some pre-prepared questions for them, and we're going to focus on, we've heard a little bit more about what the needs are, who is in need, and now we're going to focus on how do we reach those who are in need. So first of all, I want to introduce Viet, who has come all the way from Vietnam. Thank you so much for joining us on the other side of the world. Viet works at Lighthouse. Was that me? I hope you all are awake now. I saw some eyes closing, so we're in the worst session of the day for sleepiness. All right, so Viet is from Lighthouse in Vietnam. He's also a young researcher, and Lighthouse works with young key populations in Vietnam as well. So Viet, today we have heard a little bit about the specific groups of adolescents who are in need and what their needs are. I wonder if you could tell us a little bit about the young people in your context in Vietnam and what needs that they have.
Totally. So in Asia Pacific and Vietnam in particular, the HIV epidemic looks a little bit different. So the concentration or like the heaviest burdens of the epidemic lie among the key populations. So that would mean men who have sex with men, which I will later abbreviate as MSM, transgender women, people who are inject drugs, and sex workers. And in Vietnam, the population that receives like the highest concentration for the HIV epidemic are men who have sex with men. And in the past few years, over 70% of the new infection are occurring in young men who have sex with men, especially like the age bracket below 25, and the age of sexual risk behaviors are running really young, so as early as late secondary school or early high school. And in regards to like the needs of these populations, I definitely have to mention the fact that the primary driver for service uptake among this population is how services could be destigmatizing. So that would mean like their sexual orientation would not be frowned upon. That would mean that their sexual needs would be appreciated, and the fact that these services that we are offering to them must be sex positive and not to be sex negative against their needs. That would lead to the fact that they demand a higher level for confidentiality, and that would just mean that it doesn't necessarily mean just like a room with like walls, but it has to be like a room with the kind of walls that would block sounds and with more rigorous sort of confidentiality protocols among clinics. And another thing that I would like to really highlight here is the fact that a lot of young men who have sex with men really demand services to be delivered by the community themselves. So that would be among other peer educators, among other young folks who would have a closer relationships with them. So that's how you would see that in Vietnam and in many Asian countries, a lot of the community services are even I guess receive more attention from young men who have sex with men compared to public health services themselves. So those are some of the needs I would like to highlight.
Thanks, Viet. I'm hearing some really key things there in terms of confidentiality, peer providers, things that we also hear in this region as well. So we appreciate that. I'll now hand over to my co-chair, Damaris.
Thanks, Ali. And I like how Viet mentioned something that is really important when providing services to young adolescents, peer support. We know we always depend on the young peers to work with them, to support them, and also just to give that hand and reach out and get to know how they're doing and give them a shoulder to lean on. So I have a question to Jenny. And your analysis indicated the importance of adolescents and young mothers as a group that are at risk of poor outcomes. How do you think the antenatal clinic and the postnatal clinic services can better support the needs of this population?
Thank you so much for that question. Yes, so kind of leading on from the point that I had in my conclusions, obviously it's better to reach adolescent girls and young women who, where we are already reaching them. So if they are mothers, then obviously ANCs and PNCs are services that they'll already be accessing. So these are easier gateways to be able to find them. And so therefore integrating it into ANCs and PNCs would make sense, and also with the HIV testing, right? If HIV testing is happening at these clinics, then also it would make sense to raise PrEP awareness there as well at the same time. So with integrating, obviously there are lots of things to consider as well, and I went to a very interesting and very informative session run by Pata just now. Shout out to Pata, which was really cool. But obviously when we think about integrating, the ideal thing, and then this is looking at reviews as well, obviously we don't have enough kind of systematic reviews on PrEP yet, but looking even just at ART integration, for example, which we have more evidence on, like it does show that obviously, and we've had so much in this workshop as well, integration is the gold standard, but obviously we do need to think about kind of different considerations. The ideal situation would be the one-stop shop, you know, the adolescent AGYW mother turns up at the ANC, and then they are able to get HIV testing, PrEP, everything that they need in one go. Because then, you know, that removes access barriers, and that maybe also promotes confidentiality, right? They don't have to go to different places, it's just all done in one go. And it also might just be more, better for them, because they have so many other logistical kind of barriers that might stop them from going to clinics. But obviously when that's not possible for one person to provide all the kind of services, then you could also look at, for example, co-located services. So having different things in one, like, you know, infrastructure. And again, kind of, you know, with that, it could be something simple like having good signs at these co-located infrastructures so that adolescents, they can see, oh yeah, this is exactly where I need to go, and that they won't get confused when, and then obviously this is something that was mentioned very clearly in the PATA session just now, like, you know, that they don't feel overwhelmed, they don't feel confused when they go to these clinics. And also, again, shout out to the peer navigators and educators, many of whom I've met and are really cool. Go you guys. But you know, they are really key at, for example, helping to guide these AGYW when they are at the clinics to the right places, and then they feel less, they feel like they're welcome. They're actually like, yes, we are welcome here. It needs to be, AGYW friendly, right? Like that's kind of all the key messages. But yeah, and even with Qual's work that we've seen from studies such as PrEP-PP, they've actually done qualitative interviews with adolescent mums, like pregnant, breastfeeding and pregnant, and then all the mothers in that qualitative study, for example, recommended that PrEP continues to be offered in ANCs. So we can see that that is, you know, a key kind of way to think about how to better provide things at ANCs. But obviously, like I said, there are lots of considerations like healthcare worker burden, burnout, all those things that, you know, I can't cover everything obviously in this one kind of quick answer. But yeah, with all these considerations, we should really make healthcare services more efficient, so that when AGYW access and other adolescents as well access healthcare, you know, they can just go to one space at one time, get what they need, and they don't have to keep coming back to the clinic. They don't have to wait in waiting rooms for ages. And you know, if they can get what they need in one go, rather than having to come back, that would actually also, in the long term, help to reduce, for example, clinic waiting times, and hopefully the burdens on healthcare workers as well. Yes, I think I'm going to stop there. Thank you so much.
Amazing. Thank you. So bringing in a lot of those, the gold standards that we have around adolescent responsive services there, and making sure that they are integrated into all the places that adolescents are, including antenatal and postnatal clinics. Thank you so much. I now want to head over to Daniel. Daniel, I think maybe Wale needed some of your data for the, the debate yesterday, because it's super interesting that actually having access to information and mass media is protective. I want to ask you then a little bit more around social behavior change and then also education, because that came out quite strongly in your presentation. How do you think we can leverage these platforms to be better? Also considering, you highlighted the lack of access as well, so particularly to digital ones. Thank you.
Okay, thank you for the question. Yeah. Social behavior change and education are quite robust and impactful platform that we should take opportunity to utilize and drive behavior change. But we need to be cautious on how we approach it. And the first thing we need to consider is to know our target audience. If we are planning to talk to adolescents in a certain region, we need to know what are their needs, what are their preferences, and also to have in mind the cultural sensitivity in that particular area. Based on that information, then we can now tailor a message to speak to this particular group. And the message has to be clear and very concise. When I was making slides for the presentation, I was cautioned and said, don't be too technical because we have a diverse audience and we have adolescents, and I hope I did justice to my presentation. Yeah, so we need to bear that in mind as we are developing message. But most importantly, adolescents have said it, nothing for us without us, so stakeholder engagement, they have to be part and parcel of this social behavior change communication and education. We want to hear how they want the message to be phrased and to go out there. Beyond adolescent stakeholders, we also have other authorities that need community leaders, and policymakers also need to be on board and to have their input as we are developing messages. Then once we decide to share this message or to throw it out there, we can capitalize on various platforms that are available. We can use the media, the TV, the radio, the newspapers, and now with technology we have the website, we have the social media, and when we're dealing with adolescents, carefully choose where you're posting your message if you want to reach a wider audience. It's easy to catch attention of adolescents when you throw something on TikTok or on Instagram than when you put it on Twitter or LinkedIn. Yeah, so we need to have all those things in mind. Also, what has worked in various community use of influencers. Yeah, adolescents always identify themselves to certain, popular persons in the community. Those can also be brought on board during community events, and they can be utilized to educate the masses there. One important thing is to monitor and evaluate the impact of the message. What message that was working 5 years ago might not have the same impact today, so we need to stop and see, to do a before and after analysis and to see what are the impact change that we have out there, then to go back and redesign and reframe and rephrase our message, then continuously engaging this. It shouldn't be a one-off event, but continuously we need to engage the community and make sure that the message is updated to meet the requirement. But also, the family plays an important role, very important role. Behavior change and education start from home, start from the family. And we have, unfortunately, that we do not have that habit in most African community, particularly in Zambia, don't have that habit of discussing sexual issues at home with our young ones. And most of the things that they learn it from their peers, or they learn it on their own. And that is something that we need to really work on and change. It's a lot of work, yes, but it has to start now. Thank you.
Amazing. Thank you, Daniel. So multi-platforms, multi-pronged, as you were saying in your presentation, multiple platforms of information and I guess communication with different communities and people who influence the lives of adolescents. Thank you so much. Damaris, over to you.
Thanks, Alice, for that. And I actually have a question for Viet. Yesterday, we were taken through digital platforms and how they're used in programming for HIV and SRH. I just wanted you to tell us more about how back in Vietnam you have used digital platform to reach out to adolescents that are most in need. Thanks.
So under time constraints, I won't be able to go into like the nitty-gritty on the data and like the statistics, but I do have the numbers here. So in the Q&A, please bombard me with those questions. I love stats. But in the 3 minutes that I have to sell you these two ideas, I mean like the two programs that we've been doing as hotcakes. So the first one would be our app. It's called Hunt. And the primary tool for this app is for a service location map. That's like the primary tool, but like there are many appendices to this app, and it's just not like a regular app. So within this app, a lot of young men who have sex with men could find, even a lot of different, health news, whether that be like the latest, like innovations on HIV. That could be long-acting injectable PrEP. That could be other innovations or services like in their own neighborhood. But one distinct feature that I would like to highlight about this app is the fact that within the service, like location map itself, not only do they, can they find the services themselves, and they could actually book the services upon this app, but they could find a lot of other information on other locations that would be relevant and meaningful for MSM themselves. So that could be gay clubs, that could be saunas, that could be among other social events and venues as well. So I feel like that's like the number one feature that really sort of like hone in their interest and actually gave us a lot of service uptake for this app. The second initiative that I would like to highlight is the fact that we could use multiple platforms of social media to enhance service uptake in person. So for us, we do have a community clinic called the Lighthouse Community Clinic that is a one-stop shop model that Jenny already mentioned. So here at this clinic, these young MSM, they could find all the services that they would need. And that would mean, STDs, STIs, HIV testing, prevention, treatment, also mental health, and also harm reduction. So we run 3 different channels and 3 different campaigns. So the one page is for the clinic itself. Like another platform is K=K, which is like a Vietnamese version for the U=U message. And the third platform is called HiFun for a lot of young men who have sex with men who do participate in chemsex, and that would be drug-assisted sex. So 3 different platforms, but they kind of like adopt the same models to awareness raising and also sort of behavioral like information messaging as well. But for these different platforms and social media, we have seen that a lot of folks actually sent DMs to to these pages, and those are the opportunities that we could use to kind of like direct like these potential clients to to our clinic. And we have seen that 40% of the clients at our clinic learn about the services from these different social media. So that's a huge source that we could use to potentially reaching to the hidden population. So I'll keep it short there, but I'll save the savvy stats for the Q&A.
Thank you so much. So using the entryways of kind of platforms where young people already are. Yeah, fantastic. So I'm now going to call on, I don't want to butcher your first name, so I'm going to use your last name, Ms. Ruzibe. Is that correct? So she presented yesterday around young women who sell sex, and we would just like to hear a little bit from you about some of the approaches that you are using to find young women who sell sex, because they're often a hidden population, particularly those that are engaged more in transactional sex. Yep, thank you.
Okay, thank you, Alice, for that question. So maybe first to respond, young women who sell sex are found everywhere, anyway. Wherever you can find something that can be exchanged with sex, you find young women selling sex. So that is very key when we target our programs in various areas. We need to move away from targeting the obvious hotspots into targeting those adolescent girls and young women that are deep in the rural areas. So in the DREAMS program, we've made use of various screening tools where we actually have found many young women who sell sex deep in the rural areas. But something of interest is that most of these young women who sell sex are non-self-identifying. And as such, even uptake of HIV prevention services is compromised because of that. So I think for us to reach out to these young women who sell sex is to really have a rigorous screening process to actually find them in areas that we don't think we can find them. Because unless we target those areas, we won't see them. The other thing is to get services to where these young people are. We need to move away from offering youth-friendly services at the health facility, because we've realized that even if nurses are youth-friendly, but as long as they are stationed at the health facilities, young people don't go there. So in our programming, we've moved away from the health facility and offered health services in safe spaces where young people are free to discuss and disclose who they are and actually access clinical services that they think are of importance to them. So moving forward, I think we should focus on those areas. Thank you.
Fantastic. Thank you so much for your insights. So Elona, we're going to quickly come to you. You mentioned many risk and protective pathways really to help our understanding of how we reach adolescence, specifically poverty. And I know that you're also very passionate about the role of social protection. So I wonder if you could just explain to us a little bit about how we can leverage other sector programs beyond health to reach adolescents in most need. Thanks.
Thank you, Alice and Damaris. And this is a big question that really varies a lot by context. So if you remember this morning when we were looking at the proportions of households that received social protection in different countries, it varied from, if you may remember, a few percent to 36, 34, 40% in, I think, Namibia. And in the South African context, for example, we have quite high coverage of one of the methods, the child support grant, for example. So layering or adding on additional programs to, say, social protection, which is a really good entry point because it means that already we know families that receive that support already are in need. Someone has done the check. That can really, that would really vary by context, and also what can be done in that space. So in the case of Ujana Salama in Tanzania that I mentioned earlier, the existing grant social protection system was enhanced with adolescent peer-based models together with a productive grant. So young people were trained on business development and then they were given grant to actually start a business or earn an income. That would be quite different if our entry point is maybe schools. So if we have a really high enrollment rate in secondary education, that's a really good entry point to add on programming to schools, whether that is something linked specifically to food security, if that's an issue in the area. It could be school feeding programs, and it could be gardens, it could be more training for agricultural and other skills. That would obviously be added on to information on health and HIV and SRHR. But it can also be other types of health services, especially since COVID-19, when multi-month dispensing has become more common, and community delivery points for ART are much more possible. We're seeing quite a lot of gaps in addition to the missed opportunities that Jenny mentioned in integrating in other spaces. So if a lot of, and this is the work Dr. Tlhokoma Mankalaza, who's in here and has a poster, a lot of young mothers are going to facilities to take their children for immunization, but they're not actually accompanying those to their own HIV visits, and not even those living with HIV, let alone for testing and PrEP and others. So, and finally, there are spaces where young women who are married early cannot actually just show up and access some of these platforms. So we then need to think about other gatekeepers. How is having a man who is maybe married to a much younger partner an entry point, safe entry point to reaching those young women with services? And this may work in reverse in different types of relationships. It's not only in a very heteronormative space, but we have a lot of early marriage in our communities and a lot of barriers. Over.
Thank you. So very much understanding your context and understanding the risks and the risk pathways as well. So thank you for that, Elona. All right, we now have not very long for a Q&A. Over to you, Damaris.
Thank you, and I hope, Karen, you'll give us a bit of time. So your Q&A is dependable on how much time you take, because we're about to break for tea break. So the longer we stay, the longer the tea gets cold. But I think we can stay, and we just ate lunch. So I'm going to take questions. I'll have one right in front here where Alison is. The number two, the guy in spectacle just as me. Number three, okay, I'll take number two behind, I'm sorry. The lady behind. So we'll start with number 2. Go ahead.
Can you hear me?
No. Is your mic not working?
How about now? Okay. Thank you, everyone. This was really insightful. I was it's mostly based on Daniel's presentation. Sorry about this. Sometimes when we talk about behavioral change, we do unintentionally shift responsibilities and burdens to individuals instead of institutions. And my question to the whole panel actually is, how do we change social norms but at the same time continue to hold institutions accountable, whether religious, public institutions, educations, healthcare systems, in a way that does create that kind of sustainable environment and safe environment in the future. Thank you.
Thank you. Number 3.
Thanks very much. It's a comment on Jen's presentation. Yeah, okay. Since yesterday, a lot of presentation are mainly focusing on a girl child, hence forgetting that also a boy child is a driver of high new infections. So my comment is, if when it comes to education, we need to educate both genders, because also men or boys have a key role to play in preventing new infections.
Thank you for that. Alison?
Yes, so thanks for really good presentations. I have a question, I guess thinking a little bit more on the lines of the last person who asked the question. You know, when we talk about transactional sex, I like to hear what you said about thinking beyond that. But I also just want to push a little bit on, we oftentimes focus on women, all women, including trans women, but I don't feel like we ask men or boys about transactional sex, and I think they do too. And I just wonder if you can comment on how we're eliciting that and then how we're addressing that for those individuals as well.
Thank you, Alison, for that. And actually, this also takes us back to the question I asked you to ask your neighbor. Who is in need? Did your neighbor give you an answer? Really? Your neighbor didn't give you an answer before our wonderful panelist goes back. So you need to get an answer from your neighbor first before we hear from our wonderful presenters and panelists. So Jenny, would you like to go first, or Elona, or Viet?
Maybe I'll just address the question of transactional sex and adolescent boys and men and older men. I found myself sharing a summary of evidence in Eswatini specifically. We were there for a workshop, and there's actually several papers and research from Pop Council colleagues which really bring the stories of how men felt in transactional relationships with young women. And it really struck everyone in the room who had come there to talk about AGYW, so Ngosa, I hear you, about the girls, how these papers described how challenging it was for the men to also be in these spaces and not knowing, you know, provider love, that the only way that you can show your love for someone is to provide. So I think it's really important to acknowledge that definitely it takes two people to have sex, or many more than two sometimes, but that negotiating all of these is not there's not one entry point only. There's many ways to have these conversations. I wanted to highlight that for younger children, and this is why adolescence is both so beautiful and so complicated, differences don't emerge at one specific time point. So a lot of our early violence prevention and social protection programs and education as a social vaccine, they really make a difference to both adolescent boys and girls. Obviously, gender and sexual identity and social norms start playing a big role, and peer pressure in different ages and life stages. But there is a lot of the background foundational work that we do to address the structural drivers that works for both adolescent boys and girls.
Okay, maybe just to add to that. So I've realized that where I work, there's a tertiary institution, a university, and a lot of the young boys that are at that university have approached us wanting to be enrolled into the program where these young women who transact sex are also enrolled. And they came wanting also services that are being given to these young women. So yes, boys who transact sex are there. I think it's time we become deliberate in focusing on boys as well that transact sex. Thank you.
Viet, anything to add? Anything to add?
Okay, so I'm going to take a jab at the behavioral change / norm question, right? I personally think that like this question is super important given how there's so many like awareness raising and like behavioral change campaigns and a lot of things like that being advertised. But I think in order for us to be effectively, I guess, like changing like the behavioral aspects of a lot of like risk behaviors, I feel like we have to hit like the 3 E's. And like the 3 E's here, I mean like effective. The second one is ethical, and the third one is empowering. And the first point that I would like to make is the fact that for a lot of key populations, a lot of their risk behaviors are already branded as, you know, risky or you know, harmful in many spaces. So like that's, so I feel like as programmers, as researchers, as policymakers, we have to be aware of the fact that we're also sort of cementing and perpetuating this culture that are actually sort of transmitting those messages to the key populations themselves. And if that's the only thing that they get to hear, you know, like that's the only way that they get to act, right? So I feel like as we understand that there exists that culture, we would be more informed in our decision making, not to, you know, affect campaigns that would further marginalize them in the ways that we have already done so on a daily basis. And the second point that I would like to make is the fact that we should make incremental, I guess, proposals. I'm not calling them changes as enforcing aspects, but like proposals to them that would match their current cultures or practices. At least like that I know that among a lot of, you know, like men who have sex with men, there exists like a culture of seeking transactional sex on a lot of like geosocial apps. That seems to be the culture, but the way that we here at Lighthouse, like our rationale behind that Hunt app that I mentioned earlier is the fact that we're mimicking that behavior, like their behavior of hunting, you know, like hunting for sexual partners on these apps. But we're allowing, you know, for a lot of young men who have sex with men to hunt for services that meet their needs. And then they could use like various tools such as like the map that I mentioned to you. So anything that would be very kind of like close to their culture, we could use that as an inspiration for behavioral change interventions.
Thank you very much. I'm really sorry that I have to close the Q&A due to time. I'd like us to appreciate our amazing panelists and abstract presenters. And also kindly let's appreciate my co-chair, Alice here, and myself. Thank you. So I know I had promised our amazing team of young people, that is the Icon team, that they will do something before we break for tea. Is that okay, Karin and the team? Diogo, and then the panelists can also dance as they exit the podium. Kindly. We come back at in the next 20 minutes. So we are breaking and we'll be back at 4:40? 4:40, right? Yeah. So 10 minutes. 4:45, 4:40. Icons, you're welcome on stage. A round of applause as they come.